Welcome to DocTalks, where complex medical topics
become easy conversations with me, Dr. John Martin.
And me, Dr. Brianna Walton. So come on over to AAMC and get a dose of the doc. Well, we've talked a little bit about management without surgery. We'd like to bring out our next guest, Dr. Gandsas, who is our director for bariatric surgery. Please join us. Thank you. Thank you.
How are you?
So, why don't you just start telling us a little bit about the bariatric program and how you got started here at Arundel Medical Center?
Sure. Do you know what bariatric means, actually?
I do.
Isn't that a chamber that you go into?
No, not even close. So, you know, when you ask the question, people tend to answer, well, something with pressure, perhaps. But bariatric actually comes from the Greeks, where bari means weight and iatros means study. So that's part of the medicine that study problems with weight and those related with weight. So bariatric medicine or bariatric surgery, in my case, is the surgery particularly targeting weight problems. And you asked me how I started this. I started approximately 12 years ago. I was hired my first job, and they asked me, we'd like to start a bariatric program. And at that time, I barely was able to spell bariatric. But I was a long road, and we've been very successful in setting up different programs. At AMC here, this is my fourth program. So the difference between these programs and others is that the focus is not the surgery. But what we're trying to do here is more like a wellness approach. Our program is composed by multidisciplinary professionals that will help the patient go through the journey. And by the way, surgery is one of the components. And when that time comes, I'm consider myself the plumber, because I'm the one dealing with the guts and stomach. But when you look at the bariatric program, it's more than that. It's the psychological aspect, it's the physical therapy aspect, it's the nutritional aspect, and so forth.
Well, that goes along with our hospital theme, living healthier together. So
absolutely.
We're glad to have you.
Yeah, absolutely.
So oftentimes, and you know this very well, both of you, from our residency training, the medicine doctors and the surgeons are somewhat at odds. It's like the sharks and the jets on West Side Story. We get on either side of this, and all you want to do is cut, all you want to do is pop pills. But it sounds like, from what you're talking about, this is something where the two of you coexist and work together in a very effective way where you actually get along.
Good point, John.
Actually, it's very true. Surgery is not the solution. Surgery has its major impact the first 3 years. Let's say have surgery today. So this will be like rebooting your computer. When you press Control, Delete, and the whole machine shuts down and then start back again, and it's clean and it's fast and you have a fresh start. But this won't last long, regardless of what procedure you may choose.
Change your lifestyle.
It will probably take you 2 or 3 years, and hopefully, during those 3 years, you'll engage yourself on a program such as Dr. Satter's to help you change the course of action. I always say that if I'm overweight 100 pounds, I'm on a collision course. Something's going to happen unless I change course and unless I change the directions. And this is what surgery perhaps has a first impact on changing that drastically, but if I don't keep working on that with such program that we just heard, you know, the tendencies will go back to where it was before. So it has definitely, there's a synergy between those programs and those two approaches.
You used the word impact, and that's an important concept. So you had a patient that you were going to talk to us about. Do you have a video about it?
Yes, let's share what Daniel's story, which is very interesting.
My name is Daniel Fluharty. I teach both high school and college, and I adore teaching. I was always heavy as a baby, child, youth, teenager, young adult, and I maintained being obese. But I have used Weight Watchers, I've done the lean cuisine meals, I've been a member of TOPS, Taking Off Pounds Sensibly, and when I realized that I needed to do something for myself, I just couldn't do it with dieting. I thought maybe I should look into gastric bypass, and so I did. There is minimal, absolutely minimal pain because most of the surgeries are done laparoscopically. My highest weight was approximately 342 pounds. One of the health issues that I really had to deal with was high blood pressure, and some of the medication that I was on caused weight gain. I was pre-diabetic. My family has a very strong history of diabetes, and I was close to a heart attack or a stroke. Growing up, as I said, I was always fat, so no matter what, I was fat in my head. I was never good enough. If someone were laughing, they were laughing at me because of my weight, even though it had nothing to do with me. They could be telling a joke to a friend. I saw it as me. As a teacher, if kids were talking, they were talking about me. I did not go into the surgery telling people that I was having surgery. It was private, it was my business. My parents were the only family members to know. I was losing weight. I was losing very quickly. My doctor left the area to go out of state. I'm fortunate, however, because my doctor relocated to Arundel Medical Center. And when I saw that he was there, I made an appointment instantly to see him because he was my support. He was my medical support. When I went back to my physician, I was afraid that I was going to disappoint him because I've gained weight since I was at my lowest, and I've always measured myself at my lowest. My surgeon looked at me. He said, let's look at numbers. He gave me numbers, he gave me statistics that related to my success. I didn't have that success. I didn't see that success. I didn't realize that success. And even though he told me everything my friends and family have, what they said didn't matter. The moment the surgeon who did the surgery said to me, Dan, you are at the healthiest you have ever been. You are at the weight your body should be at. At your age, your height, you are fantastic. You're fine. Right now, my weight is approximately 200 pounds. I am a firm supporter in gastric bypass. If I could have, I would have done it years ago. I support it. I recommend it, but I'm not going to say I encourage it, because you need to find out first, do diets work? Are you heavy because, as I said, you're eating a whole pizza versus having a slice but still gaining weight? Gone. Gone. I am as far from being diabetic as you can get to. I haven't had a real headache in 7 years. I'm more confident than I was. Probably the biggest change with confidence is I'm more of a risk taker. There's things I'll do now that I wouldn't have done before. I have gone cave tubing. I have rock climbed. I'm going to go hot air ballooning. I've got a skydiving opportunity. There's such a major change. But if you see that you're ready for it, go talk to the physician. See what you need to do to be eligible, and then go for it.
Is that your patient or your agent?
That actually, we did Daniel a few years ago, and I think it's a good example of someone who is really committed not to participate in the first piece of the journey, which is the surgery, but the whole deal, which is the surgery, the preoperative program, the follow-ups, the exercise, and there's no free lunch, no pun intended, but it does require a lot of work and commitment from the patient.
Well, you can see from the video that he's not just talking about the surgery, he's talking about
that
the
is
lifestyle
correct. Yeah.
modification,
I'm glad you picked that up.
saying.
That's right. I'm glad you picked that up. That is correct.
You know, I've heard a lot about your technical expertise, but I have to confess I'm much more impressed with the clear relationship that you were able to establish with him and the respect he has for you. I think that bodes very well for the future of patients at our institution, and that's a ringing endorsement of the decision for us to have you here. So I'm very impressed.
I have a question. So if I have a patient who I think is obese and might benefit, like when do I know to refer this person to you?
So we first look at the national criteria for who might be a candidate for surgery. And although there's no rules for engagement, we follow the NIH rules, which basically tell us that if someone has a body mass index, which I understand you addressed that earlier on, of 40 or higher, then maybe a candidate for surgery. Or if the body mass index is below 40, between 35 and 40, but it's associated with one of those diseases that we mentioned earlier, such as diabetes, sleep apnea, hypertension, and high cholesterol, which, by the way, are the silent killers, because you don't hurt when they're present. When there's an association with one of them, obviously that person may be considered for as a surgical candidate. Patients who have a history of trying and attempting medical management and they keep on failing may be considered candidate for surgery. And obviously, patients trying to stay away from big psychotropic drugs. We make sure that if someone is in need of that, they're actually properly absorbed. So this is, at large, the overall criteria that we use.
Okay.
So that's the decision we use to send you. How do you decide, okay, it's time. You're a good candidate for surgery. We should proceed with
So
that.
we first would like to invite everyone to our bi-monthly seminar sessions where they have like a snapshot of where bariatric surgery is, and they may decide whether it is something that for them or not. As if I say, okay, I'll listen to the lecture and say, okay, but maybe I can do that, or it's not the time for me, I'm going to wait. But once the decision is made, I'd like to move forward, it's just a matter of just picking up the phone, make an appointment, and show up and to have a chat in the clinic, and we'll decide what's the next move.
And for you, you use those standard criteria that they're over 100 pounds, done all the right things,
Yeah.
and then you make that decision.
That is correct. Yeah, we use those criteria.
Okay.
That's right.
So under the umbrella of bariatric surgery, I know there are 3 main surgeries that you do, the bypass surgery, the lap banding, and the sleeve. Can we talk a little bit more about those?
Absolutely. So in the menu, we have 3 well-known
Don't
procedures.
keep saying stuff like that. I'm getting hungry
Yeah.
just sitting up here.
So the first...
Damn.
The first operation that we offer, not necessarily in that order, but they're there. And some patients may feel, oh, I like this or like that because A, B, C, and D, is the lap band or the adjustable band. And you
So
can
you're gonna
see on,
describe that for
I think
us.
we have a,
All right, so this is the lap band.
that's right. So you can see what you're looking at is the anatomy of the stomach. The stomach is a big bag that we carry in the abdomen, and that's communicated with the esophagus, which is the tube that you see in the upper part of the slide, and then they will continue with intestines. So if you look at the stomach, you see that there's a belt around the upper part of the stomach, kind of choking the stomach. That's called the adjustable band. And this is placed surgically through small little incisions, and this band is hooked up to a tube. And this tube is hooked up to a special port underneath the skin that allows the surgeon to inject some water to adjust the band. So the band can get a little smaller or a little larger, like you'll be adjusting the belt. It's interesting, I have a patient of mine back in the days, she figured out how to adjust the band at home. So she got a syringe and started adjusting before Christmas or Thanksgiving. And I was wondering, how come she's not losing weight? And so
Leave it to the ladies.
Until we caught her. Then said, hey, time out, I can't do this. Obviously, it's dangerous, but it doesn't work. I mean, the point here is that if you're one of these devices, you have to make sure you understand how it works. You have to be committed. If you're like me, I admit I like chocolates, and so if you think about it, the band can be tight enough to stop those chocolates just to go through, right? But if you're like my dad, that he likes meatballs and pasta, then the band may work for him, and that's the idea of how we present this operation
Do you
to our
have
patients to
a video
understand.
of the
Yes, if we
actual
can run the
surgery?
video, probably that can be a little more explanatory.
During a minimally invasive procedure, an adjustable band is placed around the upper part of the stomach, creating a small pouch. The band is connected by thin tubing to an access port below the skin. Through this port, your surgeon adjusts the lap band by inflating or deflating the inner lining with saline. As the band inflates, the stomach outlet becomes smaller. This helps reduce or restrict the amount of food you eat and slows the emptying into the lower stomach, helping you feel full sooner and stay full longer.
That's pretty good. All right, how about gastric bypass? That's what Daniel had.
So that's right. The gastric bypass is a much more complex operation. Now, if you look at the next slide, you'll see why. It does involve dividing the stomach and dividing the bowel. So if you look at the slide again, at the picture, Once again, you see the anatomy of the stomach, but you notice that it's cut, dividing the upper part.
A little more complicated.
And that's right. As you can, and the small bowel also is being cut in such a way that when we eat now, whatever we eat, piece of tuna, what have you, it will go through that upper part of the stomach. It looks like a small little pouch and has the size of an egg. Very, very small, usually 3 ounces. Then needs to negotiate that tubing, which is now the bowel hooked up to that. The joint between that pouch or stomach and the bowels is approximately the size of a quarter. So it's very, very quite small. So once the food negotiates that, it goes all the way down until it meets the other side of the bowel. We bring the juices from the stomach, and looks like a complex operation, but that's how it works, because no matter what, we will bypass the stomach and the small bowel. That's the word comes from. It's bypassing. So because we're bypassing the stomach and part of the intestine, those calories will not get absorbed. So the end result is weight loss.
Can you fit a Big Mac in that?
It will take you a few hours, perhaps. But you probably, that's not a good idea. We have a video, actually. That's right. Let's roll it.
All right, so we got a video here.
Gastric bypass is a restrictive and malabsorptive procedure that results in fewer nutrients and calories being absorbed. It reduces food intake by cutting and stapling the stomach to make a small stomach pouch. The small intestine is cut, and the lower section is directly attached to the new pouch. Food then passes directly into the lower portion of the small intestine, bypassing most of the stomach and upper intestines.
So that's how it works. It looks like it's 3 seconds video. It takes a little like an hour plus to do in the operating room.
Yeah, I look at this video, and what are you doing in there all day? That looked pretty quick.
I know. I wish I'd be that fast.
All right, you got one more for us,
yeah,
right?
The third one.
And the third one, operation that we offer is actually we brought this in Maryland, 2006. It's the well-known sleeve gastrectomy. And again, you see the anatomy of the stomach, the esophagus in the upper portion, the upper part of the slide, and the small bowel and continuation of the stomach. The technique pretty much involves dividing the stomach vertically, as you can see in the slide. That part of the stomach that is divided is removed, and the part that stays looks like a banana shape or a sleeve shape. That's what we call gastric sleeve or sleeve gastrectomy. Now, what happens when I eat that cheeseburger that you offer me? I only will need probably a couple of bites for me just to feel full to start with, because they have less capacity. But interestingly, studies have shown that by removing that larger part of the stomach, I am removing certain cells that secretes a hormone called ghrelin, and ghrelin is the one responsible for our sense of hunger. Interestingly, patients undergoing sleeve gastrectomy, they will tell me, Dr. Gandsas, I'm not hungry. Well, you gotta eat something. No, I know, but I'm not really hungry. I don't know what happened with my hunger. It just went away. Obviously, we need to encourage those patients to eat, because you cannot go around without eating. So the mechanisms that allows patients to lose weight following sleeve gastrectomies is by 2 ways. First, reducing the size of the stomach, and then by reducing the amount of ghrelin in their system, therefore have less hunger.
So you'll figure out how to do this, but what do you do to prepare a patient for these surgeries?
So we have a very interesting preparation phase, if you will, something that is unique to this institution. I would say the first one in Maryland. We call bariatric optimization program. And the concept is very simple. This operation, obviously, they are important operation and do represent a stressor in the life of a patient. A stressor like running marathon. And I'm not going to sign up for a marathon tomorrow if I'm not really trained for it.
Right.
So it makes sense for me to train and prepare myself for that event ahead of time.
Yes.
So I think with this kind of surgery, the same approach will be beneficial. Therefore, we have established here at AMC a program, as again, it's called Bariatric Optimization Program. We'll invite the patients to join a rehab program months prior to their surgery date, where they will not only train them and make them stronger from the muscle standpoint, but we improve the performance on the heart, the lungs, so with the intent of minimizing not only the surgery time, which is true because we shrink the liver, so in the technical aspect actually help us, but also from the anesthesia standpoint. We expect that they're going to wake up faster, better, stronger, with less side effects, and actually walk the first day of surgery. And hopefully that will allow us to discharge them actually sooner. The goal is to discharge the day after surgery.
Now, of these 3 surgeries, which one do you do more commonly?
Well, it depends. It's a combination of patient preferences, insurances, but the most operation that I do is between the sleeve and the gastric bypass.
And then finally, the sleeve, we had another video so we can see that.
Yes.
Sleeve gastrectomy is a restrictive procedure that limits food intake by cutting and stapling a thin vertical section of the stomach to make a smaller, narrower stomach pouch. The remaining larger portion of the stomach is then permanently removed. Unlike gastric bypass, there is no rerouting of the intestines. However, the sleeve gastrectomy involves permanently removing a large portion of the stomach.
Interesting, when you look at outcome data, the outcome data regarding the sleeve compared to the gastric bypass are very similar, not only in weight loss, but in terms of resolving all the health issues. Those silent killers that we were talking about earlier, very good at dealing with diabetes with 60 or 70% of resolving or improving diabetes, as well as hypercholesterolemia, hypertension, and sleep apnea. So it's a very effective operation.
And Dr. Sutter mentioned about, in terms of women and hormones and having problems with uterine cancer, there's also some effect on fertility.
Now, let me tell you a story about this. Years ago, when we were always trying to explain to the patient that as you add BMI and pounds on your body, the amount of estrogen that is generated by the fat cells is such that acts a little bit like a contraceptive method. So it's not unusual to see patients with higher BMI that they are not fertile, they cannot ovulate. So what happens when you start provide an intervention that actually provide weight loss, call it starvation or surgery, what have you, the levels of estrogens will go down and those patients start to ovulate. And I always tell my patients, be careful, because right after surgery, you're going to start ovulating. Okay, dog, whatever. So there's a lot of kids named Alex or Alexandra in Baltimore. For those who never really believe in what I was saying, but it's true. Weight loss does improve with fertility. Yeah.
I would be a little careful telling that story. There's a few things. So I've got a couple of questions for you.
Weight loss related.
Okay. I told you this show can be entertaining at times.
That's right.
So how do you decide which of these 3 to do? You don't have the van next to the Sajak Pavilion. They don't spin a wheel and pick which one they do.
Well, you have an interview with a patient, and once again, if I am the patient and I confess to the doctor, you know, I really like chocolates, I like milkshakes, so perhaps a lap band will not be the best option for me, or the sleeve, because they will be going through no matter how tight that sleeve or band is. Maybe a gastric bypass would be the ideal choice. Now, if my weight is related because I like big portions, you mentioned the cheeseburger earlier, or meatballs and pasta and pizza, maybe a lap band would be a good choice, or a sleeve gastrectomy. So you have that kind of conversation with the patient, trying to fine-tune which exactly is the operation that may fit for that particular situation.
The other thing is, we don't want to mention their names, but there's been a fair number of celebrities who have had this operation and got really thin, and the next thing you know, a few years later, they look pretty much like they did before. You know, I'm sure there's a number of factors go into it. How often does that happen? How successful is this, and how long-term a success can you hold with this?
So what you've seen is our patient who underwent the surgery. They were very successful the first 2 or 3 years, as we mentioned earlier in the show. But the power of this procedure ran out because you can't really sustain that for a long term. The body always will try to come back, especially if you have not changed your behavior.
Yes.
Let's say if I like milkshakes, as I put it earlier, and I have one of these operations, and I still having my milkshake, I haven't really changed that, my operation will hold that up to 2 or 3 years, but after that we'll readapt, and if I keep drinking my milkshake, I probably regain my weight. That's why it's so important to have a program, as Dr. Satters, to integrate to the surgery component and maintain weight loss for a much longer period of time.
Specifically with the surgery, what are the risks to the patients in terms of complications and outcomes?
When we talk about complications to our patients, it's no different than any other surgery in terms of bleeding, because we cut tissue, infection, because those tissue can get infected, or injury, other viscera. But I can tell you that right now, bariatric surgery is pretty safe. It's not like the old days when I trained, when we used a big, I call it samurai special. You know, you have the big slash in the belly. Now we use.
I think they go sideways, though.
Well, depends on the surgeon's technique. You know, depends where you train. But right now we use really keyhole surgeries that can accommodate really instruments that are thinner than this pen, and patients will tell you that they will relate the pain actually less than a C-section, which I cannot really. I have no idea, but they tell me that it's less than that. In terms of mortality or morbidity, it's probably as safe or safer than removing a gallbladder, according to the latest results. So it's a pretty safe operation, a pretty safe proposition.
Dr. Sutter, after these operations, have you found these patients to be more likely to follow the things that you want to do? Has it had that kind of positive impact on folks?
I think they already have their skin in the game by committing to surgery, and I think they want to get the best results they can. Not always, as Alex knows, but I think that the commitment is a big step. So I think they will get better results. Occasionally, they do not, unfortunately, as all cases. But generally speaking, they do much better after the surgery.
So what kind of support systems, if maintaining that afterwards are a big part of this process, what kind of support systems do we have in place here to keep people on the straight and narrow?
So we do invite them to come to our monthly support groups. This is run by our programs, where it's an opportunity just to address nutritional issues, psychological issues, even sometimes we talk about plastic surgery. But the most important thing, regardless of what we talk, is just to keep them engaged with the program and focus with their own target.
After surgery, do they have long-term complications? I've heard a lot about the metabolic side effects of gastric bypass in the past, and I think some of that may be historic, but does it require, so if I see somebody that's had one of these, are there some unique things I got to be aware of in a patient like this?
So when we started doing operations aimed for weight loss in the past, there were a combination of the way you change the bowel upside down and so forth, and the end result were very significant malnutrition issues. As we learn about those, we start fine-tuning, if you will, our operations, so we don't see those problems that often. However, we encourage every patient to come regularly to our clinic to get at least once a year blood samples, so we know where the vitamins and proteins are, so we can actually adjust them accordingly.
So one of the big things is obviously afterwards diet. And I think adjusting the diet's really important. We see a million different diets. But I think a couple things that ring home to me that I think people want to know answers to that are common questions. Some of which is, how do I keep from getting hungry? You know, when I get in the middle of the afternoon or even in the evening, you know, late after I've had dinner. Is there something special, some kind of food that I can eat okay to deal with the hunger? Then the other question, something you and I and Elaine talked about a little bit, is it ever too late at night to eat?
That was good.
There's a couple good questions there. First one being is that you have to eat in order to lose weight. There's no question about that. And you have to eat consistently, and the type of food plays a huge role in that. Everybody has a little sag in the afternoon, so sometimes a healthy snack will get you through that, just like the Red Bull, John. Perfect choice there. And then in the evening, maybe it is a little too late, because we know that if you eat late, particularly a calorie-dense food with lots of calories, and then go to bed, that's not necessarily best for your metabolism. Half the time, people are snacking at night because they're already overtired, and they really should have gone to bed anyway. They're trying to keep themselves up by eating, and sometimes it's better just to cut your losses and go to bed early, which a lot of our patients do. Types of food, certainly we talked about the blood sugar consideration. If you keep going from one blood sugar hit to the next, it's very stressful for your body, and that's when you're going to get into the hunger phases. But we have very large men, actually, who are doing the program, eating 1,200 to 1,400 calories, and they're saying, I can't eat all this, which is remarkable. But they're eating the right foods, because the food industry does know about how much they have to put in there to make you really, really hungry.
So a good restaurant tip for them, and one I think I've learned that I think is a great take-home message, I'd be interested in your opinion, is One of the things I try to do is we either share what we order, because I think almost every place you go to gives you more food than you need. Well, the other thing is ask for a box right from the get-go, divide it in half, put it in there, put it under your seat, because I know if I'm like any of you, I'm still sitting there, we're still talking, the meeting's still going on, I'm still eating. So I don't know, are those kind of useful tips, or are there others that you suggest to people so that they keep out of, when they go to a restaurant, eating too much?
The bread basket's always a great item not to have delivered to the table right away. And if you tell them right away, don't hide the bread basket underneath the seat. So that's another one. And certainly the alcohol consumption, well, of course we don't do that up here, but we do know that that's a straight line to the waistline for calories. So make sure you drink a big glass of water before you go out, so you don't spend so much money on the
You look
bill.
uncomfortable, John.
Well, the wine industry just took a big hit right there. I don't know. You know, there are a lot of people employed by the alcohol industry across the United States, and we have an unemployment issue. So,
Thanks for doing your part.
yeah. So is that, and I guess the other big thing about diet, and I'd be interested to hear what you say to your patients post-operatively, I think alcohol is a big one. It's a big part of what we do. Mm-hmm. We give the heart and vascular talks and say, well, alcohol is actually a good thing because it has positive effects on cholesterol. Now I've got my vascular surgeon says, have a drink. My nutrition, diabetes experts and my bariatric surgeon says, don't you dare touch alcohol. What's that poor guy supposed to do?
Well, he has to know who he is first. So there's some people can do fine with one or two, other people can't. And if you're really struggling with your weight, one of the quickest ways to derail your program is to start drinking alcohol. So I've just seen the failures time and time again. Sometimes it's better to let it go. It doesn't mean you can't have some fun on the weekends or a couple of days a week, but consistently on a nightly basis, if you're trying to lose weight, that's a way to shoot yourself in the foot.
It's an interesting question. When it comes to bariatric patients, the fact that we are rearranging the anatomy, the way the alcohol absorbs is much faster. So first I have to warn them that maybe a glass of wine, if they're planning to drive after that, they may get in trouble with the police because they'd be probably the levels of alcohol, which may be higher after surgery than they were normal before surgery. So basically they become really cheap dates after,
That's good.
after this procedure.
That's a good one. Well, you guys have given us tremendous advice tonight. I think you've been very, very helpful, very informative.
Very informative.
And I'm pleased to have you both here. I know you've been here for a while, and I didn't know you before all this, and now I'm really glad we did this show because clearly this is one of the most important issues we face, and obviously your work now speaks for itself. So thank you both very, very much.
Thank you for having us.
Thank you.
Thank you.
Thank you.